Hello, web shadowers. Welcome to our final virtual shadowing session for this semester. Thank you all for joining us this afternoon. Today, we have the pleasure of welcoming Dr. Janiczek, who will be teaching us about anesthesiology. As always, please remember that the Google form will be posted in the chat box and at the description of this video when the session is over. With that being said, Dr. Janiczek, you may start whenever you're ready.
Awesome. Thanks for having me. Let me just pull up my presentation and we'll get started. All right. Hi, everyone. My name is David Janiczek, and I am currently a cardiothoracic anesthesia fellow down at the Ochsner Clinic in New Orleans. I'm also the founder of Get Admitted MD, which I'll touch on at the end of the program today. But today we're going to talk about cardiac anesthesia, which is something that, as you can tell, I'm very passionate about and I really enjoy. So hopefully you guys can pick up some stuff and learn a little bit more about what I do on a daily basis. So what we're going to talk about today, I'll go through just a brief introduction. I'll talk about what is anesthesia in general. I'm going to glaze over that very quickly because I think there's a lot of more interesting stuff later on in the PowerPoint. So I'll talk about what exactly cardiothoracic anesthesia is, what the path is to become one, and my typical day, the patients I interact with on a daily basis, some cool things that we do every day. We'll talk about a case really quickly, and then we'll finish with why become a cardiothoracic anesthesiologist. So my journey so far started out in Iowa, a small town on the eastern side of Iowa called Bettendorf. I then went to the University of Iowa where I studied physiology and business. And then I went to medical school at the University of Iowa where I graduated in 2017 and then moved out to Chicago where I went to the University of Illinois, Chicago. Did my anesthesia residency there. And now I am down in New Orleans at the Ochsner Clinic where I'm doing my cardiothoracic anesthesia fellowship. So I think it's kind of nice to highlight, some factors that made me want to go into anesthesia. Maybe you guys relate to these and maybe this, is kind of where you're headed in the future as well. So I really love the, the fields of anatomy, physiology, pharmacology, and kind of blending those all together. I know that's the cliche answer for anesthesiologists, but it really is true. Like you got to love those fields and make sure that, that's something you want to be dealing with on a daily basis. If you don't want to be memorizing drugs and doses and how to use them, then maybe that's not the best field for you. But if you do, it's a great field. And so that was kind of the basis for my choice to go into anesthesia. Secondly, I really loved acute physiology. Things happen in the operating room very quickly. And so, we have to be able to intervene on those. For example, if a patient has low blood pressure in the operating room, we have to know first, what's going on, and then second of all, how to treat it. And so just being able to do those things, I, find that very interesting and it keeps me, I guess on my toes and, nothing is really boring in the operating room from that perspective. So I really like it that way. Third, we get to interact with tons of different specialties on a daily basis. You could be in the same operating room and the first case could be a general surgeon, the second case could be an OB-GYN, the third case could be a pediatrician. It just really depends. And so we have to kind of know a little bit about every single specialty, and we, need to know those things so that we can take care of those patients in the best way possible. Fourth, there is a procedural nature of anesthesia. We're not as procedurally oriented as surgeons, but we do some fun stuff. So intubation, central lines, arterial lines, which I'll talk about later. They kind of break up your day, make things interesting. It's, you can throw epidurals in there as well if you're doing some labor and delivery anesthesia. And so that's really a really good mix of things that we do. And then lastly, I had a desire to be in the OR environment. So I knew I didn't want to be a surgeon, but I knew I wanted to be in the operating room somehow. And so, sometimes the operating rooms can be intimidating, can be challenging, but, I love being in there. It just feels like time is, standing still and it's great. So I, knew I wanted to be that in that environment, but I didn't want to be a surgeon. So anesthesia is kind of the next best thing. And, that's, basically this summarizes the reasons that I chose anesthesia. So what is anesthesia? From a 10,000 foot view, it's really a diverse field of medicine that allows surgery to happen in a controlled environment with reduced pain for the patient. So, we're everywhere from the operating room, all types of procedural areas. So if you're having a GI scope, a colonoscopy, upper GI scope, anything like that, we're there for the most part, providing patients with sedation and anesthesia care. We also do, very intense procedures such as open heart surgery and brain surgery. So we're pretty much everywhere in the operating room and procedural areas of the hospital, but we're also outside of the operating room as well. So, you can find anesthesiologists in the intensive care unit as critical care physicians, as well as, now we're moving more into, executive suites of hospitals and kind of trying to get our expertise at that level as well. So really, anesthesia is made up of 4 pillars. If you guys have watched my talks before, you've seen this slide. So basically, analgesia, first and foremost, is pain relief. Obviously, we want patients to be in as little pain as possible during and after surgery. So we can give medicines to accomplish that. Muscle relaxation is a second pillar of anesthesia. So we don't like to use the word paralysis because it kind of scares people, but muscle relaxation is something that we do for certain surgeries. If the patient's having a robotic surgery or some other types of surgeries where, it would be highly detrimental for that patient to move even a millimeter. So we use medicines to help their muscles relax and basically not work for a temporary period of time. And then we reverse that at the end of the procedure. Amnesia is the loss of memory. So we don't really want, patients to remember the peri-surgical time, the time a little bit before surgery and then during surgery and after surgery for a couple hours. So that's often a stress-inducing time. And so if we can eliminate that with medicines, hopefully patients will have a better experience that way. And then lastly, unconsciousness. This basically just means that they're asleep. Obviously you don't want to be awake for surgery. And so, we use medicines to make you unconscious and get you through the surgery that way. So on the bottom here is kind of the spectrum. And so as you can see, on the far left is the awake state. On the far right is the asleep state. In the middle, I've put the sedated state. So awake, we can use what's called local or regional anesthesia. This is very akin to what dentists use when they numb up your mouth with Novocaine before they take a tooth out or something like that. That's a form of local anesthesia. Regional anesthesia is a little bit more, we may numb up an entire extremity. So say you're having shoulder surgery, we can actually just numb up your shoulder and most of your arm. And that way, you can have the surgery done without needing to go all the way off of sleep. In the middle is the sedated state. So sedation or monitored anesthesia care. Basically, we give you a little bit of the medicines that we do for general anesthesia, but not enough to the point where we need to put a breathing tube in and hook you up to a ventilator. So this is used for minor procedures, things that don't need you to be completely asleep. And so it's a really good tool we have to, avoid giving you a ton of medicines and all the side effects that are associated with that. And we can kind of just give you, let's say, a medium dose of medicines and, get you through the surgery that way. And then finally, asleep, general anesthesia. That's what you probably think about when you think of anesthesia. So if you're having your gallbladder out, for instance, you'd have, general anesthesia. We give you a bunch of medicines through the IV and get you off of sleep. And then we place a breathing tube once you're asleep and hook it up to our ventilator, which gives you medicines through that breathing tube in the form of vapors that you breathe through the breathing tube, and it gets absorbed by your lungs, and then you stay asleep that way. So that's typically what you think about with general anesthesia. So let's move into cardiothoracic anesthesia. So basically, this is a subspecialty of anesthesia focused on taking care of patients undergoing cardiac or thoracic surgery. So cardiac, the heart, thoracic, the lungs. And so you could break it down pretty simply that way. I'll go into a little bit more depth into some other types of patients that we take care of, but those are the big two. This field is evolving due to the changing cardiothoracic surgery landscape. The goal with that is being less invasive procedures when possible. So, 10 or 15 years ago, there was a lot more cardiac surgery going on. People were getting their chests cut open. It was a different time. And so now we have a little bit more, transcatheter based approaches. So I'll go over what that is in a few minutes here, but we can replace your valve. We can, do cardiac stenting if you have blockages in your heart. And so those are, a little bit less intense, less invasive, and still have good outcomes. So the number of cardiac surgeries are going down, but at the same time, there are still a few situations where you need to do that. So the other big component of cardiothoracic anesthesia is transesophageal echocardiography, or TEE. And that's something we get as fellows. We get trained in TEE every single day. We're doing multiple of these exams. We really get good at seeing what, the heart looks like from the inside. And I'll show you an example of that later on as well. So what's the path to become a cardiothoracic anesthesiologist? So 4 years of undergrad, just like every other pre-med student, 4 years of medical school, just like every other medical student. And then you move on to 4 years of anesthesia training. That includes the 1 year intern year, and then 3 years of the anesthesia residency itself. That's where you rotate through different, areas of surgery. So general surgery, ortho, neuro, cardiac, all the different subspecialties you rotate through, and you really learn how to take care of patients in the operating room. And then at the end of that, you can decide to do a fellowship or not. It is not required to do a fellowship. You can graduate from anesthesia residency, go out and get a great job and have a fantastic career, and you never need to do a fellowship. It's really if you want to do something specific. So cardiothoracic anesthesia is a fellowship, neuro anesthesia is a fellowship, pediatric anesthesia is a fellowship, OB-GYN or OB anesthesia is a fellowship, critical care is a fellowship. So you really have a wide variety of fellowships to choose from. It's more based on what you're interested in and what you're willing to give up one more year of being an attending to, stay back and do another year of training. And then you're finally done after that. So I'm here almost at the end of the road. I can see the light at the end of the tunnel, which is great. But it does really go by very quickly. So if you look at this timeline and you're like, that's a long time, don't worry, it does go by really quickly. And before you know it, you'll be done and out practicing on your own. So I just want to touch on my typical day. This is not representative of every cardiothoracic anesthesiologist, but I can only speak to what I do. So I get up usually at 4 a.m. Between 4 and 4:15ish and 5:30. I work out, eat breakfast, kind of get ready for the day. Leave for the hospital at 5:30. Get to the hospital, change into scrubs, and head to the operating room. Around 6, we meet the first patient between 6:30 and 7. And then the goal is to get the patient in the operating room by 7 a.m. That's usually the first case start time. So we, induce anesthesia, get the patient asleep, do our arterial line, central line, do our TE exam. The midday, we give our residents lunch. We're usually working with a resident as a fellow. So we'll give them lunch, and then, we'll be able to take lunch ourselves at some point. Usually between 1 and 3 p.m. we finish the first case. This is where it kind of varies. If you're at a hospital that does, their surgeons are really quick, you may be done, by 11 or 12 with the first case. Typically our cases are 1 to 3. If there's a second case to follow, usually we start around 3 to 4 p.m. with that case. That goes till sometimes midnight or 10 p.m., somewhere in that range. But if there's no second case, then we, finish the first case, and then we usually head home around, 4 to 6 p.m., I would say, on average. Obviously, there's earlier days, there's later days, but on average about 4 to 6 p.m. So then the evening hours are typically, eating dinner, reading, studying, making sure we look up the patients for the next day. And then I try to be in bed around 9 or 10. So as you can see, this is a, pretty busy day. And so it's, it goes by very quickly. And so, it's, some days are easier, some days are harder, but this is kind of the average day, I would say. So let's talk about my typical patients. So first and foremost, the patients we take care of are typically very sick. Most of the time, the patients we take care of don't have isolated cardiac disease. What I mean by that is they have, diabetes, they may have kidney disease, they may have had a stroke in the past. There's just, lots of problems going on with these patients. And so you kind of have to, look in their chart and dissect everything, which I'll go through in our case study a little bit later. I want to split, our patients into, really 4 big categories. So 1, patients having cardiac surgery. So patients having surgery on their heart. That one's pretty straightforward. Structural heart. So this is the new field. Where we're replacing valves and those types of things through a catheter that they place in the groin. These are the minimally invasive procedures. Thoracic surgery, that's lung surgery. So maybe the patient has a lung mass that they need to get resected. We can take care of those patients. From our perspective. And then one thing that we don't always think about, but is kind of going to be more popular in the future, is cardiac patients having non-cardiac surgery. So maybe a patient has a really bad heart, or their valve's not working properly, but they're having non-cardiac surgery. Maybe they're having a colon resection, or their gallbladder out, or you name it. We may be able to assist in taking care of those patients, maybe a little bit better than just a general anesthesiologist, depending on how sick the patient is. So at this point, I want to talk about some cool things in cardiac anesthesia, and hopefully you guys think these are cool as cool as I do. So first, transthoracic echocardiography. So this is basically looking at the heart from the outside of the chest. So this is an ultrasound probe, and you can see the screen up here. Basically, this gives us some pictures of the heart, in a very minimally invasive manner. It doesn't really hurt the patient. There's very, very little risk, if any. And so, this is usually the first step in kind of taking care of these patients is getting we call it a TTE, a transthoracic echo, and just getting a sense of what their heart's doing. We can tell how well it's squeezing. If there's valve issues, we can tell that there, everything like that. So these are some of the images that we would get with a transthoracic echocardiogram. So you can see, this is the image that we would get on the screen, and a little diagram showing you which chambers and everything that you're looking at. So you can see the LV here with the thick wall. This is the left atrium, right atrium, right ventricle. You can see the wall is much thinner in the right ventricle than it is the left ventricle. You can see the valves, this is the mitral valve, tricuspid valve. And so you can basically turn the probe in different orientations and get these different images. And so this will kind of relate to what we do with transesophageal echo, which I'll show you in a few minutes here. This gives us a good idea of, a lot of things about how the heart's functioning. So double lumen tubes. This is something we do for thoracic surgeries. So if a patient's having part of their lung resected, we would use a double lumen tube. So up here in the top left corner, this is a single lumen tube. This is your traditional endotracheal tube. So this is a little cuff that goes in their trachea, and then the tube usually, maybe sitting all the way up, their mouth may be like right here, their lips, and then this part's sticking out of their mouth. Just one, basically one, lumen in that tube, versus this one has two lumens actually. And you can kind of see it here. It's usually called the bronchial and the tracheal lumens. And so what this does is this allows us to isolate one lung and only ventilate that one. So most of the time we use a left-sided double lumen tube. And as you can see, the left side the left refers to which side the curve goes. And so this is a curved tube. And then, there's a balloon here, and then there's a balloon here in the trachea. And in this situation, we could ventilate either the right or the left lungs. And so it's a nice tool to have, and be able to, give the surgeon the best views possible for operating on whichever lung they need to. And so we do that by basically, clamping one of these lumen, and then that will deflate the lung, and then we'll just ventilate through the other lumen. All right, so let's talk a little bit about structural heart stuff. So this is probably the most common, at least at the moment. So it's called a transcatheter aortic valve replacement. So maybe 10 years ago or so, this, maybe up to 15 now, this is, they really started doing these. They're also referred to as TAVRs. So this is a minimally invasive way to replace someone's aortic valve without the need to cut their chest open. And so, it's mainly used for aortic stenosis. So basically a narrowing of the valve. These procedures are performed by a cardiologist with special training, typically referred to as an interventional cardiologist. And the big thing about these is they don't necessarily need general anesthesia. So these procedures can be done under the sedation or monitored anesthesia care, because really once they get the catheter in the groin, that's the most uncomfortable part. The patient doesn't actually really feel, when this system is inflated. So basically what they do is they bring this catheter up. This is the descending aorta up into the aortic arch, and then the ascending aorta. And then they bring this balloon system across the aortic valve, and they basically just inflate the balloon. On the outside of the balloon is this mesh-like network, which inside this has the valve. So it basically just expands into place. And then they pull this catheter system out and the valve stays in place. And it, works, hopefully it works right away. Sometimes there are some issues with it. But this is a really good, technique. It's, been scientifically proven, and it's really, a great tool that we have for certain patients. The next one is called a mitral clip. So one problem that, some patients have is called mitral regurgitation. So the mitral valve can become leaky for a variety of reasons. But basically what that means is mitral regurgitation means blood is going from the left ventricle back into the left atrium, in which case that should not be the case. It should be kind of a one-way valve. So it should go from left atrium to left ventricle. So as you can see by this picture, this is basically a leaky mitral valve. So this hole is bigger than it should be. And so what they can go in there and do is very similar. So they bring a catheter up, this time through the venous system, so the IVC, go into the right atrium, go across the interatrial septum into the left atrium, and then they cross the mitral valve and basically place a clip on the two mitral valve leaflets and basically close the hole to be smaller. So it doesn't close completely, and the goal is not to close it completely. They just want to close it to be smaller. So therefore the regurgitant volume is less. Once again, this is performed by a cardiologist, and these procedures are performed under general anesthesia for the most part at this point, just because there's a little bit more risk here. And it can get a little complicated in some patients. So the patients need to be fully asleep for these procedures at this point. Similarly, a Watchman procedure or left atrial appendage occlusion. This is used for patients with atrial fibrillation, which is basically an arrhythmia where the atria do not contract correctly. The left atrial appendage is this little outpouching from the left atrium. Basically, blood clots can form there in AFib, and those can lead to strokes and just bad things. So some patients will need to have this, basically closed. And so the Watchman procedure is essentially this basket-like device that sits into the left atrium, as you can see here, and it basically stimulates the formation of clot. And then there's a little basically a wall there that forms. And so the clots actually can't get out. And so, the clots just kind of stay there. Blood doesn't go in and blood doesn't come out. So kind of just, clots off the appendage. You don't really need the appendage, to survive. And so that's, not going to be an issue for, going forward. And it's less, it's more risky to have the clots in there and potentially come out without the basket. So, this device is really awesome. And has been used for years now. All right, so let me jump into a typical cardiac case and kind of show you what I think about, what some of the different components are, everything like that. So, our typical patient, 70-year-old male presenting for aortic valve replacement. He has hypertension or high blood pressure, hyperlipidemia or high cholesterol, coronary artery disease, but he's got some stents in the past. So, we're less concerned about, his vessels at this point. He does have severe aortic stenosis. So basically a tightening of the aortic valve. His valve area is 0.5 centimeters squared, which, I don't expect any of you to know what that means. It's very small. So anything less than 1 centimeter squared is severe. And so this guy has, very small aortic valve area. So basically not as much blood is getting through the aortic valve with each heartbeat And so it's, he could have a risk of stroke, lots of bad things can happen. So we need to get this fixed. He's also got diabetes. He's a little bit obese. His BMI is 34. And then he's got a little bit of heart failure as well. His ejection fraction's 45 to 50%. A normal is 60 to 65%. So you can tell it's a little bit reduced, but not, drastically. So before I go into it, if I read this kind of prompt, what am I thinking? And, how do I approach this case? So the first thing that comes to my mind is this guy's sick. His heart's not really working that well. He's got aortic stenosis. And so, we need to get the surgery done and get him fixed. So basically the next thing I would think about is, what do I need? What equipment, drugs, monitors do I need to take care of this gentleman in an effective and safe manner? So, we're definitely gonna do an arterial line, which I'll touch on in a second. We'll definitely do a central line. Drugs, how am I going to get this guy asleep without dropping his pressure too much? And then, what medicines, should I use to, bring up his blood pressure, boluses and infusions, and then also what emergency meds do I need in case something really goes wrong? Equipment, we need a transesophageal echo machine, which, is pretty readily available in the cardiac operating room. So we'll definitely have that in there. So then I started thinking about my plan. So how am I going to get this, gentleman asleep? Most people will say, you can still use propofol, which is kind of the workhorse of anesthesia to get people asleep. You could also choose a medicine called etomidate. If the patient had a little bit sicker heart, I would, their ejection fraction would say 25%. I would maybe think about etomidate then. But as long as you, are very diligent with the propofol and very careful, you can still use propofol in that situation as well. Other questions I might think about, what am I going to do if the blood pressure starts going down? Or, how can I prevent it from going down before it even does? So those are just some things that I think about, before a case of this nature, and kind of gives you a clue of what goes into our minds. So this is, really a flow of a cardiac case, and I'll go through these kind of stepwise as we go forward. So first thing, we get the patient in the operating room. We move them from the transport bed to the operating room table, put some monitors on. So we'll put a pulse ox on, so it monitors the concentration of oxygen in the patient's blood. We'll put a blood pressure cuff on to get a couple of readings before we get our arterial line. And then we'll also put on our EKG sticker. So we'll monitor the electrical activity of the patient's heart throughout the procedure as well. So a pre-induction arterial line is really key in cardiac surgery. So what is an arterial line? So basically this is a special IV that's placed in an artery instead of a vein. And it allows us to measure blood pressure on a beat to beat basis. So every time the heart beats, we get a blood pressure. And so this is, a lot more crucial in cardiac surgery than some other types of surgery where we need, to know their blood pressure every single second. It also allows us to draw blood back for labs more reliably than an IV does. So an IV, the vein could collapse. It could, not have enough blood in it to, give us, good blood flow. The artery is not going to do that based on the nature of the thick walls. And, it's just not going to, break down like that typically. We most commonly place these in the radial artery. So this is a diagram of, usually where we place it. So you can see this would be a left radial arterial line. So the artery kind of courses like this towards the thumb. You can usually feel your pulse right about in this range, right, on your wrist. And that's usually where we go for our arterial line. So we'll basically insert it just like an IV, and then hook it up to special pressure tubing. And it gives us a waveform that looks like this red line. So as you can see, every time the heart beats, and a few milliseconds beyond that is when we get a pressure waveform. So this is an arterial pressure waveform. And so as you can see, it gives us a number. So 130/74 is this patient's blood pressure. And so, we can, look at this waveform throughout the procedure as it's continuously being given to us. And we can tell, okay, maybe it's, his blood pressure is dropping. And so before we even, see the number, we can see what the waveform looks like, and we can, react much quicker to his dropping pressure if that is the case. We can also place arterial lines in the brachial artery or the femoral artery as well. I just say the radial artery is most common because most people have a very easily palpated radial artery, and it's a little bit easier to do awake. Femoral artery and brachial artery are pretty hard to do awake. And so in this case, we want to do we want to get this blood pressure monitor in before we give all these medicines and get them off of sleep. So we need to do it awake. So it's a little bit more tolerated than these other locations. All right, so let's move on. We've got the arterial line in. We're going to move on to induction and intubation. So induction of anesthesia in cardiac patients can be quite challenging. Each pathology has different hemodynamic goals. So aortic stenosis is different than mitral regurgitation, so on and so forth. The other big thing is that the patient's heart doesn't necessarily respond like a normal healthy heart. And so what I mean by that is sometimes we expect, their pressure to, react a certain way, and it just does the opposite. Or it's slower to react. So if we give, medicines to help bring the blood pressure up, then it could take 20, 30 seconds for that to really kick in, versus in a normal healthy heart, it may take 5 seconds. So, we kind of have to be very diligent and make sure that we keep an eye on things, but also don't overreact and give a ton of medicines, because then we'll skyrocket and shoot up their blood pressure to, potentially dangerous levels on the high side. For aortic stenosis specifically, for our patient, it's crucial to not drop their blood pressure. One way to refer to this is not dropping their preload. So if you think about preload, afterload contractility, that kind of makes up, a lot of cardiac output. And blood pressure itself. And so preload is super crucial in these patients. So we want to make sure we don't drop their preload very much, which can happen with, medicines like propofol. Propofol drops, your preload, and can cause hypotension or low blood pressure. And so it's very crucial to be very careful when you're inducing anesthesia in these patients. Intubation is usually not the focus, of this period. It's still important to get the breathing tube in, in a timely and effective manner. However, we're usually more concerned about the hemodynamics and making sure their blood pressure and the heart rate and everything is appropriate. And so, if the patient has a challenging airway on top of that, it can complicate things. But for the most part, luckily they usually don't in these patients. All right, so central line placement usually happens after induction and intubation. So central lines, you guys may have seen these before. So basically, there's multiple areas where we can go with a central line. We can do a femoral line, we can do a subclavian line, we can do an internal jugular line. The basic principle behind these is it's a bigger IV, bigger tube that we can put blood, volume of crystalloids and colloid and medications through. So during a cardiac operation, we're going to give them lots of fluid. We're going to give them lots of medications. We're going to give them medications that shouldn't really be given peripherally. Blood pressure medicines, to bring up their blood pressure often are a little bit dangerous to place in a peripheral vein. And so it's better to have central access. So one of these big vessels that we can put those medicines through, and it goes straight to the heart. It's just better for everyone. And so there's a couple, this is a very stock photo, but this gives us the principle. So the central lines are basically, this is what you get in your kit. So you get a needle to basically, get access to the vessel. And then there's a wire. So you put the wire in through the back of the needle. And that basically gives you a protection for the access for a moment while you slide a dilator over the wire, and you dilate the skin, so that then this bigger IV can then go through the skin. So this is the actual IV part right here at the back. So as you can see, this is, usually they're 15 to 20 centimeters long. And so you insert this IV, and then this one has 2 ports. Some have 3, some have 4. These are kind of smaller ports. Some have 2 bigger ports. So it really just depends on the surgery and what you want to put in. But basically, this is, the basics of a central line kit, which you guys will all see in the future as med students or residents or physicians. All right, so then let's move on to the transesophageal echo exam. This usually happens after the central line is placed. So what is transesophageal echo? So basically what we do is we place a scope down the patient's esophagus, and then it goes basically behind the heart, and it looks at the heart from the inside. or basically behind the heart. So we can get a bunch of different views, and the tip of this probe can turn in different directions. It can flex, frontwards, backwards, left and right. So we can really get different angles and different pictures of the heart. The goal with this is to, one, assess the function of the heart, make sure that the function is what we, found on our pre-op TTE, and then also find out, as the surgery progresses, are there changes? So we leave this probe in for the entire surgery, and then at the end we take it out. But we can also give the surgeon information about the patient's heart, from these images as well, and can help guide them, during the surgery. So this is just another schematic. As you can see, the probe kind of, goes through the mouth and then goes into the esophagus and then looks at the heart from the inside. Very similar pictures to what we saw before with the TTE images. However, this is just flipped. So you can see the LV is on the bottom here. LA is on the top. If you remember from before, it was flipped. But basically we can, rotate the probe through different angles and get different pictures of the heart from the inside. So that's a really cool tool we have. And we can, one perk of doing the, fellowship is that we get to learn how to do this really well. So yeah, so that's TEE. So with aortic stenosis, what would we see? Basically this is a picture looking at the patient's aortic valve. So the aortic valve sits right here in this image. The left ventricle is down here. The aorta is here. And so we would essentially see what we call color flow acceleration, or turbulent flow is another way to look at it. So we can throw a color spectrum on this image. And if the heart was beating itself, we'd be able to see it with each heartbeat. But basically we would see a bunch of, color. This is a bunch of turbulent flow, meaning that there's a tight orifice there, that the blood is basically squeaking through and causing all this turbulent flow. If the valve is open, to a normal degree, you wouldn't get turbulent flow like this. You would get laminar flow. And so you wouldn't get all these, the change, the differences in colors. It would usually be just one color, red or blue, depending on which direction it's going. And so you wouldn't get all this turbulence. Another way we can look at it is, basically what we call Doppler. So basically the TE probe has the ability to basically throw a Doppler signal through the valve. And so that's what they're doing here. And we can measure, this is each time the heart beats, this is the flow velocity of the blood through here. So you can see the Vmax, or max velocity, is 416 centimeters a second, which is in the severe aortic stenosis range. We also get pressure gradients across here. So, we're looking at all these numbers, when we obtain these images, and we can grade the stenosis based on, these numbers into, mild, moderate, or severe. And so one thing that we can do is look at the TEE images, in the operating room, and see if they align with what the TTE showed ahead of time. So it's a little bit of a double check, and also, things change when the patient gets in the operating room. We can assess that as well. All right, so moving on to the surgery. So I like to just divide it into three phases: pre-cardiopulmonary bypass, the cardiopulmonary bypass phase, and then post bypass. So basically pre-bypass, the surgeon makes an incision through the skin in the chest, and dissects down to the sternum. Sternotomy is then done, which basically the sternum is cut in a vertical direction from basically the xiphoid to the manubrium. And then basically they open up the chest and do some more dissection down to the heart itself. They expose, the big vessels, the aorta, the vena cava, and then also the heart itself. We then give a large dose of heparin. So heparin is a blood thinner. And what we really want is to prevent any blood clots in the cardiopulmonary bypass circuit. The circuit is essentially thrombogenic, meaning it's going to cause clots if we didn't give anything. And then those clots would get returned to the patient, cause strokes and very bad things. So we definitely want the patient to be fully heparinized. And so we give a really large dose of heparin, and we monitor activated clotting time, or ACT, throughout the procedure to make sure that it's still, their blood is thin enough to basically continue. If not, we just keep giving heparin and make sure that the ACT comes back in a range that we're happy with. Once dissection and heparin are all in and given, then, basically a cannula is placed in the aorta, as well as usually a separate cannula in the IVC. This is the most kind of basic setup. There's different ways to do it as well. But this is, for the most part, the most common and basic way to do it. And this is what cardiopulmonary bypass looks like. So here's the venous cannula in the IVC. Usually goes in the right atrium and then down into the IVC. This sucks blood into this reservoir, which is sitting next to the patient in the bypass machine. So then the reservoir then goes to usually a heat exchanger and oxygenator. So basically there's oxygen that is pumped into the blood. And then it goes through a set of roller clamps, a filter, back to the aortic cannula. And then this is the aortic cannula. And so then the blood is allowed to basically flow back through the heart, back through the body. So this is the bypass of the heart. So it sucks blood out from basically where blood returns into the IVC and right atrium, and then pumps it back to the aorta to go to the rest of the body. The goal of cardiopulmonary bypass, like I mentioned, is basically remove the heart and lungs from the circulation so that the heart can be worked on in a still environment. However, we obviously need to oxygenate and, keep the waste products, out of the blood. So we still need to filter out CO2. We still need to, make sure the patient's oxygenating well. And so this is the way to do so. And then once the bypass circuit is in place, then we can stop the heart with cardioplegia, which I'll talk about on the next slide. And so that's really just to allow the surgeon to work on a non-moving target. So this is a picture of a cardiopulmonary bypass machine. As you can see, there's lots of dials, lots of screens, lots of numbers to look at. This is the job of a perfusionist. So someone that goes to school specifically for running this machine. So they're very, very integral into the cardiac operating rooms. And so they're really important to, they're essentially keeping the patient alive during the bypass. Anesthesiologists keep patients alive before and after the bypass. And then during bypass, the perfusionists really are the ones controlling everything. But as you can see, can be very overwhelming. And there's a lot of things on there to change, modify, look at and keep an eye on throughout the procedure. So the surgery itself, once the cannula are placed, they're hooked up to tubing that goes to the bypass machine, which sits next to the operating room table. Like I mentioned, cardioplegia is given. The patient is also usually cooled. So the bypass machine can cool the patient it depends on the surgery. Sometimes as cool as, 20 degrees centigrade. If it's that's called deep hypothermic cardiac arrest. We only do that for certain surgeries. For the most part, they're usually cooled to anywhere between 28 and 32 degrees centigrade. What that does is it really decreases the metabolic demand of the tissues and the heart itself. So it's a way of protecting the heart from any potential ischemia or lack of blood flow during the bypass run. The more technical aspects of the surgery, I would leave to a cardiac surgeon. I don't want to step on their toes. But this is kind of, the basics. And then we move on to the post-bypass period. So basically every 20 minutes or so, throughout the surgery, we're giving cardioplegia to basically, maintain that still target and keep the heart from beating. So once we're ready to start coming off bypass, we'll stop giving cardioplegia. We'll often actually give something called a hot shot. So it's a warm dose of cardioplegia that then, basically warms the heart back up and helps it get restarted. We also, from the anesthesia side, give medicines to keep, help the heart beat again. So maybe epinephrine. There's others that, maybe given as well. And then, we may need to defibrillate the heart. So basically apply electrical energy as well to restart it. So at this point, the transesophageal echo or TE becomes really important to assess the new valve and make sure there are no issues with it. If there are, we may have to go back on bypass and, have the surgeon fix it. But if everything looks good, the cannula are removed, the heparin's reversed with protamine, which is the antidote for heparin, and then the patient's chest is closed. The sternum is reapproximated with sternal wires, and then the skin overlying is closed with stitches as well. So that's basically, in a nutshell, what a cardiac case looks like. Obviously, we could spend hours talking about it. And so I tried to condense it into something that was manageable and, hopefully you got something out of it. I just wanted to touch on really quickly why you might want to become a cardiothoracic anesthesiologist. First and foremost, I think you have to have an interest in cardiac anatomy and physiology. We're surrounded by that every single, hour of the day. And so, if you don't like the heart or don't think it's interesting, maybe not the best field for you. But if you do like it and, you could see yourself doing it, I think it's a great field. It's not what it used to be, but at the same time, I think it has a strong future as well. You got to be, wanting to do complex cases. So like I've kind of hit on multiple times already, most cardiac patients are very sick with many comorbidities. So they have a lot of stuff going on. You got to kind of balance many different things. Then, if you want to get echocardiography training, this is, one of the best ways probably to do it in terms of anesthesia. And so, as I've mentioned before, it's an integral part of the cardiac operating room. So, some people become cardiac anesthesiologists because they want to, be really good at echo and be, an expert in that. And then lastly, you may want to take care of sick patients outside of cardiac cases. So like I hit on before, we're taking care of more and more cardiac patients for non-cardiac surgery. And I think that trend is just going to continue as patients get sicker and sicker, and we're, operating on sicker and sicker patients. And so, we're not going to be limited to just the cardiac operating rooms. We're going to be, definitely involved in a lot more non-cardiac surgery, but our expertise will be needed, just because the risk can be very high. But we're used to it by, dealing with these patients on a daily basis. All right, so I just want to touch on this really quickly. Get admitted MD, we help you get admitted to medical school, started in 2018, from personal statement prep to secondary essays, mock interviews. We're here to help get you accepted in medical school. And I say we very, generally, because it's only me. So you will work directly with me. I don't have any other individuals helping me. And so if you're looking for kind of a personal advisor throughout the whole process, then here is my contact info. So you can email me, check out my website. I have a few different avenues to contact me as well on here. So I will leave this up for a second, but I will take any questions you guys have. I see two questions in the chat here. So how to choose when a patient should be awake, sedated, or asleep, or when to implement loss of memory? Great question. So it really is determined. So the first part of that question depends on the surgery. So, there's definitely surgeries you just can't be awake for. Open heart surgery, you just can't be awake for. More invasive procedures, anytime we're cutting the, abdomen open, you're not going to be awake for that either. Sedated is, or sedation is often used when, we are doing procedures outside the operating room. So maybe you're having a colonoscopy, maybe you're having, an upper GI scope. So where they look in your esophagus and your stomach. Maybe you're having a coronary angiogram. So where they shoot, dye into your coronary vessels to see if there's any blockages. Those are, really good cases for sedation. Most, I would say, 90% of surgery is asleep. With general anesthesia. And so that is not necessarily a question of, the patient itself. It's more of a question of the surgery. Now, when you are, looking at, a question, like kind of a gray zone, could the patient be awake? Could the patient be asleep for the surgery? Which there are some instances of that. It does come down to, will this patient, how are they? Are they calm? Are they agitated? Are they, anxious? Those types of things go into our decision-making process as well. Those, factors are also considered. For the most part, we do, give medicines to, cause the loss of memory. For most patients, I will say some anesthesiologists, don't really do it after age 65. because there's a small risk of delirium in those patients. So if the patients are really old, sometimes we just skip those medicines to cause a loss of memory, just because it can cause some other issues. But if you're young, healthy, otherwise, most anesthesiologists will gladly give you those unless you don't want it. But it also, not only does it cause that loss of memory, it also it's akin to a liquid Xanax, if you will, or an IV Xanax. So if you just want to be a little bit more calm for the surgery, when we're rolling you back, that's another instance to use that medicine. So it's not just for the memory loss aspect of it, it's also for the kind of what we call anxiolysis, or reduction in anxiety in the pre-op period. So perfusionists, they are not considered doctors. They are, there's a 2-year, I think it's a 2 to 3 year training program that they go through, but they don't go to medical school. So they go to a different training program. They can go right after a bachelor's degree. So if you go through a bachelor's program and then go to perfusion school, you can be done way sooner than a doctor would be. So they're not considered physicians. Yes, I can also help pre-PA students. That is a great question as well. Let's see, my boyfriend collapsed his lung years ago and got a drain put in. They only numb the area where they would be inserting. Yeah, so it really depends. That's a great question. If it's done in the emergency room, often, or if the drain was placed in the emergency room, they would probably not give you anesthesia. They would really just do the local. So they inject around where they're putting the tube in. That is, something that could have been, I don't know the situation exactly, if he was unstable in any way and he couldn't make it to the operating room and get anesthesia that way, then, that may have been their only option, was to, put the local anesthesia around the site and then insert it that way. It's also, not always necessary to, put a patient asleep for a drain, for a chest tube. So we often do chest tubes, on awake patients. And yes, it is risky, but at the same time, putting them under general anesthesia isn't necessarily required, or even sedation isn't always required. So it's kind of a patient by patient basis, and also the situation, whether it was in the emergency room or if it was in a different spot, that would kind of change the answer as well. Would patient with SVT end up pacemaker, or medication can be managed for the irregular heartbeat? So I'm guessing are you referring to SVT in the operating room, like under anesthesia, or just SVT in general? That would change the answer. So if it's like a chronic SVT, then, or runs of SVT that happen a lot, then, they may get worked up for a pacemaker. If SVT happens in the operating room, we usually treat it with medicines. And so we'll give a beta blocker, or something along those lines. And, then they may get, consulted by cardiology, or we may consult cardiology after the surgery to have them worked up. And then usually cardiology decides if they need a pacemaker or if they don't. And so, it's not a straightforward answer, but at the same time, it most likely would be treated with medicine. All right. So are there any other last minute questions? All right. Well, thanks for watching, and I hope you learned something. If you have any questions, feel free to reach out, and I'd be happy to answer them.
Thank you so much, Dr. Janiczek, for such a wonderful presentation. Thank you also for taking the time and answering everybody's questions at the end. So I will be posting the Google form in the chat box soon, and it would also be posted in the description of this video. Make sure to check out his socials, which will also be posted in the description of this video as well. Thank you.
Yep. Thanks, everyone. Have a good day.